Hello, my name is Dr. Julian Thambu, and I'm giving a lecture today on SLE and APS. SLE stands for Systemic Lupus Erythematosus and APS for Anti-phospholipid Antibody syndrome. The learning objectives are to describe the diagnostic criteria for and clinical features of SLE and APS, and to describe the principles of treatment for these two conditions. Descriptive epidemiology. SLE occurs worldwide, and the incidence and prevalence are stated in this slide. Clearly, this condition is not common, but the incidence has been increasing over time, possibly due to increased awareness. There is a female preponderance in SLE, with 85% of patients being female, and during the postpubertal or premenopausal years, which suggests that hormonal factors are important. Pathogenesis of autoimmune diseases generally follows the schema as illustrated in this diagram. There needs to be an element of genetic susceptibility in the host, and in such a host, environmental factors trigger a disease which moves from being subclinical to being clinical. So in more detail, pathogenesis of SLE involves multiple genes with cellular events as listed here: T and B cell activation, cytokine involvement, and immune complex deposition, which are modulated by additional genetic factors and environmental factors. And these result in the typical phenotype which we call SLE. And the activity of SLE can wax and wane, and this can lead to multiple outcomes as listed here: the 5 Ds of death, disability, dissatisfaction, dollars, and drug toxicity. Clinical features of SLE are actually protean. The diagram in this slide lists some of the features. Starting from the brain, patients can develop headache, dizziness, behavioral changes, strokes, which are typically due to arterial occlusion, seizures, etc. The heart and blood vessels can be involved. The kidneys are a very common site of involvement, and certainly joints and bones can also be affected. Importantly, the clinical features of SLE or lupus do wax and wane, so they can actually be worsened when the patient has a flare and can wane or resolve when the patient is treated. And these features can develop at or after diagnosis. In Singapore, over time, we've shown that the incidence of renal disease actually increases, as is shown in this slide, and that of CNS involvement also increases. So that after 10 years of disease, about half of patients have renal involvement and about 15% have CNS involvement. These are some photos to illustrate the clinical features of SLE. So this patient has a typical Malar rash, which you can see there's erythema over both cheeks and over the bridge of the nose, sparing the nasolabial fold. Cutaneous vasculitis is very common in SLE, and as you can see here, there is discoloration of the tip of the pulp of this patient's finger, which is non-blanchable. A point of note is that this is not specific for SLE, so cutaneous vasculitis can be seen in other autoimmune conditions. It is, however, relatively specific for an autoimmune condition. One must, however, also not forget to exclude subacute bacterial endocarditis in these patients. Alopecia is very common in lupus, and as you can see here, there's diffuse alopecia with this fairly typical brownish coloration of the hair in this patient, which suggests fairly chronic active disease. Alopecia can also be patchy and scarring in some patients. As I mentioned, renal involvement is extremely important and relatively common in SLE, and can be categorized from classes 1 through 6 as listed here. Class 4 lupus nephritis is the most severe form of lupus nephritis and is basically the focus of most treatment trials in SLE. Renal biopsies are pretty important in making a diagnosis of the specific class of lupus nephritis which a given patient has, because this guides treatment decisions and the choice of appropriate drugs. Now, a key concept that is important to appreciate in SLE is the fact that disease activity, which is reversible, can lead to disease damage, which is irreversible, as is summarized in this slide. Let me give you several examples to illustrate this concept. So a patient with lupus nephritis who's got inflammation of the kidneys, if this is reversible with appropriate immunosuppression. If untreated, tissue damage leads to renal failure, which is irreversible. Similarly, a patient with pneumonitis related to SLE can actually be treated, and the activity in the lungs causing the pneumonitis can be reversed and without organ damage. However, if it is untreated or inadequately treated, then the patient develops interstitial lung disease, which is irreversible. Importantly, treatment can also lead to damage. So corticosteroids, which are used to treat inflammation, can also result in avascular necrosis or cataracts, which are irreversible. Now, there are several tools to measure disease activity which are listed here, including the BILAC, British Isles Lupus Assessment Group Scale, and several other instruments, for example, the SLEDAI, SLAM, and ECLAM. And there's one commonly used disease activity measure called the SLIC ACR Damage Index. These are the 2012 ACR criteria for SLE, which are actually summarized in this slide. A few points about these criteria are as follows. First, the criteria are cumulative. In other words, they do not need to be present concurrently. Secondly, a patient needs to satisfy at least 4 criteria, including at least 1 clinical criterion and 1 immunologic criterion, or a patient needs to have biopsy-proven lupus nephritis in the presence of anti-nuclear or anti-double-stranded DNA antibodies. Now, lupus is a diagnosis that is sometimes considered, and one needs to consider this diagnosis in several situations. Firstly, when there are suggestive clinical features, and secondly, once mimics of lupus have been ruled out. And I'm going to elaborate on these 2 points in subsequent slides. An important point of note is that SLE is unlikely in an asymptomatic patient with a positive anti-nuclear antibody. So in a patient where SLE is suspected clinically, the diagnosis can be confirmed by evaluating the presence of end organ involvement and/or complications. Secondly, by determining if autoantibodies are present. Thirdly, by ruling out mimics of SLE. Then, a baseline workup for therapy needs to be performed, and disease activity needs to be evaluated. So first of all, talking about evaluating for the presence of end organ involvement and complications. Typically, full blood count will be performed to look for cytopenias, and if anemia is present, hemolysis will need to be ruled out. Evaluating renal function is done by using the tests as listed here, and if nephrotic syndrome is present, then hyperlipidemia and renal vein thrombosis need to be evaluated for using appropriate tests. For renal vein thrombosis, Doppler ultrasound of the renal veins is typically ordered. Chest X-ray needs to be done to evaluate for serositis, which would be seen as pleural effusions or globular heart suggesting a pericardial effusion. And a troponin T, which needs to be performed, evaluated, it would suggest the presence of myocarditis, and an echocardiogram would then need to be performed. The second aspect of confirming diagnosis is by determining if autoantibodies are present. In evaluating patients for autoantibodies, it is important to understand the causes of a positive ANA. This diagram nicely illustrates that most patients are negative for anti-nuclear antibodies. In the patients who have an anti-nuclear antibody, as is shown in this diagram, the vast majority of these patients have an anti-nuclear antibody which is of uncertain clinical significance. In other words, these patients do not have a defined autoimmune disease. In those patients who do have an autoimmune disease, this condition could be non-organ specific, which is illustrated here with the term rheumatic diseases, or it could be organ specific, which is illustrated here with the term non-rheumatic diseases. So, talking about organ specific autoimmune diseases first, these include Hashimoto's thyroiditis, Graves' disease, etc., as are listed here. Rheumatic diseases or non-organ specific autoimmune diseases are the focus of this lecture and includes SLE, Sjogren's syndrome, drug-induced lupus, systemic sclerosis, or mixed connective tissue disease. So this concept is important and is the basis for the statement just previously that a positive anti-nuclear antibody in the absence of any clinical features does not equate with a diagnosis of SLE. The diagram in the previous slide also explains why an anti-nuclear antibody is not a specific test. Now, if you look at the left panel here, a test, if it is sensitive and negative, rules out a condition, and this is a SNOUT as an acronym, SNNOUT. So a sensitive test, that's SN, if negative, rules out a condition. A specific test, if it's positive, rules in a condition, and that's a SPIN using this acronym. So a specific test, SP, if positive, rules in a condition. So an ANA is not specific for lupus or SLE, because if it is positive, an ANA can be due to many things and does not rule in SLE. However, an ANA is a sensitive test. If it is negative, it almost always rules out SLE. So do remember, spins and snouts, an ANA is not a specific test. However, it is a sensitive test, and therefore it is most useful when negative to rule out SLE. There are other autoantibody tests which we typically perform in a patient with a positive ANA, and in the context of lupus, the significance of these tests are as listed here. I would like to highlight double-stranded DNA and SM antibodies, which are highly specific for lupus, and also lupus anticoagulant and anticardiolipin antibodies. These, if positive, are associated with anti-phospholipid Antibody syndrome or APS, which I'll be elaborating on shortly. Now, part of confirming the diagnosis is also the need to rule out mimics of SLE. This is particularly important because the diagnostic criteria for lupus are actually syndromic. They're based on the phenotype and not on one underlying pathogenic mechanism. And because of this, it's important to rule out mimics of SLE which can look like SLE clinically and even fulfill criteria, but actually due to another underlying cause. So what are these underlying causes that need to be ruled out before we can diagnose SLE? Firstly, a systemic bacterial endocarditis can mimic SLE with clinical features of arthritis, vasculitis, proteinuria, and even positive antinuclear antibodies. And SBE is typically ruled out with positive blood cultures, presence of a cardiac murmur, and vegetations on echocardiography. Another relatively common mimic of SLE is parvovirus B19 infection. And this can be ruled out by testing for parvovirus B19 IgM antibodies and by the presence of a positive PCR for parvovirus B19 during viremia. Importantly, these tests need to be done at or shortly after the onset of symptoms. Hepatitis C and HIV can both mimic lupus, both clinically and serologically, including autoantibodies, and therefore these tests need to be done routinely in evaluating a patient who is suspected of having SLE. Baseline workup for therapy. This includes a DEXA scan to evaluate for the presence of osteopenia and osteoporosis, and tests to rule out chronic infections prior to starting corticosteroids is listed here, and baseline lipid and fasting glucose levels. Now, measuring disease activity is important because disease activity can wax and wane. Typically, clinical features of active disease are stereotypical. In other words, patients tend to flare in the same way that they have flared previously. There are tests for evaluating disease activity as listed here, including elevation of double-stranded DNA with low complement levels. Importantly, the CRP, C-reactive protein levels, are typically normal in lupus, but are elevated in infection in a patient with SLE. So this is useful to distinguish infection from a flare, where clinically the features could go for either flare or infection. And elevated ESR is also seen sometimes in patients with active SLE. Moving on, I'd like to touch briefly on Anti-phospholipid Antibody syndrome or APS. So this is a condition where there's an increased risk of arterial or venous thrombosis, and APS is due to the presence of anti-phospholipid antibodies, which include anticardiolipin antibodies, lupus anticoagulant, and beta-2-glycoprotein 1. APS can be primary or secondary. If APS is primary, it occurs by itself in isolation. If it is secondary APS, it's associated with SLE or other connective tissue diseases. The treatment for APS is long-term anticoagulation for life, essentially with warfarin. I'd like to talk briefly about principles of SLE management. These are as follows. Firstly, the need to control disease flares. Secondly, the need to prevent recurrence. And thirdly, to prevent or reduce adverse effects of therapy. Corticosteroids are the mainstay of treatment for SLE. Low-dose corticosteroids, in other words, a dose of prednisolone of less than or equal to 10 milligrams a day, are typically used for skin and joint involvement due to SLE. Moderate-dose corticosteroids are used for patients with serositis or constitutional symptoms, and high-dose corticosteroids are used for major organ involvement. In other words, patients with major renal, CNS, gut, cardiac, pulmonary, or severe hematological involvement. And pulse methylprednisolone is used for life or organ-threatening involvement. For example, rapidly progressive glomerulonephritis, thrombotic thrombocytopenic purpura, or pulmonary hemorrhage. Antimalarials are an important part of therapy for SLE. The commonly used antimalarials are hydroxychloroquine and chloroquine, and both these drugs have been shown to reduce the risk of SLE flares. In other words, both drugs prevent SLE flares. They also have beneficial effects on lipid levels, the risk of venous thrombosis, and possibly mortality. There are adverse effects including retinal toxicity and skin hyperpigmentation, but these typically can be detected early, and in the case of skin pigmentation are largely cosmetic. Retinal toxicity requires regular follow-up with an ophthalmologist for early detection. Steroid Sparers are used in SLE to allow the dose of corticosteroids to be reduced, and in some cases because they are more potent than corticosteroids. Commonly used steroid sparers include azathioprine and mycophenolate mofetil, which has largely superseded intravenous cyclophosphamide for treatment of systemic lupus erythematosus. And the best data for the use of both these drugs, in particular for mycophenolate mofetil, comes from clinical trials in lupus nephritis. Other commonly used drugs include cyclosporin A and less commonly tacrolimus, danazol, DHEA, etc. Allow me then, in closing, to summarize the key points of this short presentation. First, SLE is an autoimmune disease with protean clinical manifestations. Second, diagnosis of SLE is based on the 2012 ACR criteria after ruling out mimics. Third, a positive anti-nuclear antibody in the absence of clinical features does not equate with a diagnosis of SLE. Fourth, treatment depends on the extent and severity of organ involvement. And fifth, anti-phospholipid antibody syndrome can be primary or secondary.